Welcome to Frontrunners Innovate, where we connect you to global leaders meeting the world's challenges through business and innovation. Our guest for this episode is Dr. David Montgomery. He's a cardiologist with a heart disease prevention focus. And he's also a well-known media persona that allows him to spread his message about prevention. He's the founder and managing partner of the Prevent Clinic in the Atlanta, Georgia area, and also the executive producer of the Good Doctor TV web series, as well as pretty much an entire portfolio of broadcast initiatives, which you'll find out quickly is a really good fit for him. Co-hosting with me is Dr. Atif Zafar. He is a hospitalist and a serial entrepreneur and investor in healthcare and technological innovation, and a man who may surprise you and Dr. Montgomery toward the end of this episode, so stay tuned. I'm your host, Mary Curick, CEO of Frontrunners Development, a global business development company that connects business to change the world. So let's get you connected to Drs. David Montgomery and Atif Zafar. So we're ready to get rolling with these two fine gentlemen today. And I want to first bring up our co-host, who is Dr. Atif Zafar. And if you've been watching Frontrunners Innovate, you may have seen him a few times because he's co-hosted a few times before. So I'm going to turn it over to him to share a little bit more about himself and some of the wonderful projects he's involved in. So Dr. Zafar.
Thank you very much, Mary. Pleasure to be here. Dr. Montgomery, very nice to meet you. I'm an internal medicine doctor, trained in internal medicine, and did a fellowship after that in medical informatics. I'm a faculty member at Indiana University School of Medicine, been there since 1997, and have been doing a lot of work in both informatics and then high technology as an entrepreneur. So I started out my career as an academic generalist and hospitalist at Indiana University, doing clinics and inpatient medicine, teaching residents, medical students. I had a $25 million grant line support, and then I've been on multiple sort of co-authored papers, a book chapter, world talking tours. On the President Bush's advisory group for electronic medical records at AHRQ. We built the National Health IT website at AHRQ. After that, a couple years later, I became an entrepreneur, started a company called Meridian Cardiovascular Systems, doing basically RF ablation for treating plaque inside arteries and using forward-looking 3D IVUS intravascular ultrasound for guidance on the same catheter. So that was followed by several other companies in high technology. And most recently, I started a chip design company. We're building our own graphics processing unit, or GPU, with a very esteemed rockstar Silicon Valley team. So I have raised funding. I'm in the process of creating a very large fund in the Middle East, along with multiple other projects in low-income housing, green energy, consumer privacy, and other areas. So very nice to be here and discuss my my background and what I.
Okay. I think, wow, Renaissance man for sure. There's so many hats. Dr. Dave Montgomery, now we want to come to you, and you are our interviewee, our guest for today. And I'm excited to have you here because I think cardiology is just a really interesting space for us to kind of play in. It's just important for, central to all of our health, and certainly it's something we all need to pay attention to. But I love the fact that you are focusing on prevention. But I want to find out, and I want everybody else to find out, where does the passion come from? What's the why? Tell us a little bit about your background and bring us into what brought you into this work.
Yeah, well, Mary, I should just say I'm really humbled by the invitation to Frontrunners Innovate. Dr. Zafar, it's a pleasure to meet you. I've read about you. I don't think the words that are on digital platforms do it even half the justice. And as I'm sitting listening to all of the wonderful things, just so many different realms that you're touching on, making a difference, it makes me wonder what I'm doing on this podcast. But it is indeed a pleasure, and I'm very happy to talk about what I'm excited to do, thrilled to do every single day. Yes, heart disease is still the #1 killer far and away of mankind on the globe. Certainly in the United States, it kills more people far and away than all the cancers combined. We've heard of all of the sort of dismal statistics. But the thing that really gets me, and what got me when I was a second-year resident, was understanding very truly that it's the only disease of its kind where we know what causes it. It kills so many people. We know what causes it, number one. Well, many cancers, we don't know what causes many of the cancers. We know what causes certain things in medicine, and we take care of it. So a urinary tract infection, for example, we're really good at UTIs. We know how to really take care of a UTI. We understand UTIs really well. We don't understand the same about different cancers. We are approximating what we think the answer is, but we know what causes the large amount of heart disease. But here's the other piece. Number two, we know how to prevent people from dying from it. So now we have a problem. It's the number one killer far and away, but we know how to stop people from dying from it. So we have a problem. And the problem doesn't lie in the science. And although the science is developing, and Dr. Zafar is working on one of the most menacing parts of heart disease, that's coronary artery disease. And how do we obliterate coronary artery disease so that people can live long, healthy lives? But the problem, in my assessment as a very young resident, Dr. Zafar, was that we have a PR problem. That the things that Dr. Zafar and our colleagues know really, really well, we know it ad nauseum. We recite it to each other in conferences. Morning report is what we call it when the residents come together, medical students, and we learn about cases. And then we go to big, large conferences where literally thousands and thousands, sometimes tens of thousands of people are there. And we are preaching to the choir, but we're missing the larger catchment, the people to whom or for whom the information can make the biggest impact. We don't have the public relations that we should. And so to me, a long time ago, that was 07, 08, relatively long time. I said, well, that doesn't make any sense. So where are people then if they're not coming to our, health fairs and where are people? Well, they're watching television. At the time, social media was just starting to catch its, a foothold. And I said, well, that's what I'm going to do. I'm going to go where people are. I'm not going to ask them to come to a health fair and come to a conference. Nobody goes to those, right? Come to our, right? It's still a noble thing. Don't get me wrong. I'm not putting down people who want to do that because it's still helpful for the people who it reaches, but it's not reaching enough people. And long gone are the days when we say it's okay to reach one or two people. That's not working. It's not okay to reach one or two people with a message that we know can save millions and millions of people. And so I said, I'm going to start. Now, to the chagrin of the people who were training me, I started, okay? I won't go into that. But I started in radio, and I did a weekly radio talk show on Dr. Zafar. I would sneak into the call room, pull up the phone, because there was no Zoom back then. I would pick up the phone and go on the air every week, the same time every week, and have my call. And I would spend 15, 20 minutes sometimes on this segment that we kind of had. We almost had an Oprah, Dr. Oz kind of thing going with me and the host at the time on the radio station in Chicago. And then I started to do some print as well. So, that got us some attention. They said, hey, you want to write for us? And I said, sure, I'll write. And then television came. So I got an opportunity to do live TV, and from live TV, talk shows. And I'll stop there for a second because the talk show is where I said, oh my goodness, I can really be me. Like, I'm kind of quirky, I'm a little silly, I'm, all these things. And you can't quite do that, Dr. Zafar and Mary. You can't do that when you're talking about Joan Rivers dying of cardiac arrest after a procedure. You really have to, you've got 3 minutes to talk about it, and you got to get those words in really quickly, and it's got to be punchy and pithy. But I found that in the talk show setting, I could be me, and me was okay. I didn't know I was okay, and I was enough, and all of those things we talk about. But me was okay because we got an email about 2 weeks after the first time I did Steve Harvey. Steve Harvey show was about 3 blocks away from Northwestern in Chicago, where I went to medical school and residency and fellowship. And a woman wrote in to the producer and said, thank you so much for doing that segment on heart disease. I took myself in, and she had a 90% RCA. She could have died. And they sent me that, and you just get this spine tingling. You have no idea how many other people you helped. But I said, that's it. Sign me up, right? Sign me up for that. And so I said, how can I do more and more media? And that's what I've been doing. Did a lot of HLN, CNN when HLN was their news unit. And now I'm the medical contributor for News Nation, which is a brand new, fastest growing news outlet on cable TV. So very proud to do that. And then I have my own outlets in podcasting and social media, because I think there's still a gap for real, honest, trustworthy information. And that's what I'm happy to do.
That's amazing. That's one thing I do know that Dr. Zafar understands, because I know that your efforts lately with some of the businesses that you're involved with has gotten some attention, and how much that helps the efforts move forward in terms of getting funding, getting to market, getting that commercialization going, and getting those things out to the people that need to get there. What, you said that I think that TV must agree with you the most, because you said you could be yourself in television. What do you feel like is the message that you're bringing? Is there one central message that you're focusing on?
Yeah, well, I think it all stems from one central message, and that is that if anybody is going to change your health, it's going to be you individually. Yeah. That the responsibility, the accountability, the action, it all has to be yours. It has to be yours. We cannot outsource our health care. We have to be the responsible parties. Well, how do we do that, though? In order to do that, you've got to have purveyors of the information to give the information, and to give the information readily. For a very long time, when I started this television thing, I mean, every time I would come back to do rounds after doing WGN, I would get, you're going to get sued. Somebody's going to, my goodness. And there's nobody. Listen, you're a fellow, you're a resident. You can't tell the attending that you're not going to get sued. But how many people are sitting around watching news saying, okay, let me just write this down. What is he saying there? I'm going to take him in for libel. Like nobody's doing that, right? So it was very foreign to everybody. It wasn't the conventional way to give the information out. And if we give the right information and we make it accessible to people, which we have a problem with now, then they can use that information to better themselves. Now, think about this. You still have to hire help. Mary, your whole life is encapsulated in the idea of relationships, world-changing relationships. That's exactly right. I used to think you have to do it all by yourself. No, you can't do it all by yourself. You can't do it. You can't really do anything all by yourself. You get the relationships. What are the relationships? Partner with people who are expressly there to help you with your healthcare. What do you mean? A physician to take your blood and then help you interpret what the data mean for you so that you can move forward. What's my next step? A massage therapist, right? A yoga instructor, right? Like all of these other elements that surround our entire being. A therapist. You're hiring people to help you be the healthiest individual you possibly can be, because there is at least one person counting on you to be healthy, right? There's somebody counting on you to be as healthy as you can be, even if that person is only you. And you owe it to yourself and all the work that you've been doing all of your life to be healthy and live the life of your dreams. That's what this is about. That's the central theme. And then we have a bunch of fun, Mary, from that central theme.
I love that. What do you think, Dr. Zafar?
No, this is admirable. I think this is exactly the kind of activity we need in healthcare to make a difference. I think that right now, I work in a level 1 trauma center as a hospitalist, and I see all the patients in the ER, admit them. And the problem we have is we have repeat offenders that come in with the same problem. They've been told, to change behavior, and it's very hard to change behavior. So central to the idea of changing behavior is what type of information and what level of urgency do we need to present that information in to make a difference? And, the question comes down to is, what is your risk for having a cardiovascular event in the next 3 to 5 years? Based on their biomedical parameters, you can basically kind of predict this person is going to have a heart attack in the next 5 years, 10 years, provide them with an actionable plan to how do you reduce that risk. And, that kind of intervention in my mind can help change behavior, because then you have to say, I'm potentially going to lose my life in 5 years. What do I need to do to change that trajectory? And, how am I going to prevent my family from having to deal with the loss of me, and my friends to deal with the loss of me? That type of an approach.
Your disease is not your disease. It belongs to everybody
That's
around
right.
you.
It belongs to
Thank
everybody
you for
around
that.
That type of an approach, in my experience, has helped people understand what the urgency with which they need to make a change.
Yeah. Well said. Dr. Dave, the very first statement that you said about how heart disease kills, I lost a good friend this week to a heart attack. She's a good 10 years my junior. She wasn't even Medicare eligible. She had diabetes. She had lost a couple of toes last year, and I was one of the pool of people that took her to her dialysis. There was something that they did to try to treat her diabetes that impacted her kidneys in some way and shut them down. And so she was on dialysis for about a month or so. She managed to come out of that, which they didn't even think she could do that. She was a Spitfire. I mean, she was the Chamber of Commerce Ambassador of the Year, I don't know how many times. She never missed anything. She had like 3 businesses to run, but she went in for a test this week. Nothing that you would indicate to you that she was about to have a heart attack, a massive heart attack, and die. Her husband took her into the hospital for a test. They sent her to Raleigh for a bigger test because they thought that maybe something they did for this test might have caused a reaction, just a simple reaction or something to it. When they took her back for that would have been a simple 10-minute test. She had a massive heart attack, and that was it. Never got to say bye to the family or nothing. And it just, it scares you to think that can happen that suddenly, and then that person's out, completely out. So she had some heart issues all along through all of this. The person that called me had indicated, she said, and it wasn't diabetes that got her. Well, we don't know that, because diabetes impacts everything, every organ in your body. I'm not saying it wasn't specifically her heart, but I'm just saying, I don't know that diabetes didn't connect in that in some way. But I do say that, looking after the heart health has got to be one of the big priorities for sure in everybody's life. And I think knowing more is really critical, and how you get that information is important. And honestly, something you said, Dr. Zafar, is the sense of urgency about that. I think a lot of times doctors don't tell you some things, or nurses don't tell you some things in terms of the tone that they use or the sense of urgency, because it's really your decision, and they want to let it be your decision to make how you address it going forward. But I think that if you don't get the sense that you need to really do something about something, you get to be very relaxed about it, or maybe you just don't follow through. I mean, I learned something this week about the number of prescriptions out there that never get filled, and it's amazing. It's up in the billions of dollars every year that just don't get filled. And a lot of times it's just, it's money versus other things, food or whatever. But in a lot of cases too, it's just, I'll be all right. It's okay. I don't need it. It's something to consider. So talk to us a little bit about your clinic, Dr. Dave, and let us know what you're doing with the Prevent Clinic.
Yeah, no, I'm very, very proud of where we've come so far. Prevent Clinic in Sandy Springs, which is just outside of Atlanta. It's all about, and the way that we do our the typeset is on purpose. So the P, R, and E are capitalized, they're all caps, because we want to emphasize that it is before the event. We want to get there before the event. Prevent. It's like when you go to the game, you don't say defense, you say defense. Really emphasize that. It's really important for people to understand that we can get there before, and that's the key to ending the abysmal statistics in heart disease, to get there before. I might even say that if your friend, and my condolences to you and all who mourn, that if she had some testing before, they may have seen something. Not necessarily always the case, but that's the problem. So at Prevent Clinic, we're all about diagnostic testing, diagnostic evaluation. If you don't test, you don't know. You made a really great point, Mary. She felt relatively fine. She felt normal day-to-day stuff. Maybe she deals with a little bit of stuff because of the dialysis. Maybe she deals with a little stuff with the diabetes, but that was just the everyday garden variety stuff. And then there you go. But truly, most of these things are brewing underneath the surface. We've all heard of stories like some of the most fit people on the planet, marathoners. We've all heard that story before. Oh, before he crossed the finish line, boom, sudden cardiac arrest. And that's not like some rare thing. We see people in very many of these marathons across the country and world have heart events. That's why the ambulances and the paramedics are out there. And it's because, in my mind, at least mostly, if not almost all of it, because we don't know, we didn't go check. Why would a marathoner otherwise go and get a heart check? Well, it's not going to happen to me. I eat what I'm supposed to eat, and I run 30 miles a week. Why would you think that? Well, we have to be thinking it because heart disease is not just the way that you treat yourself. It's not just your behaviors and your actions and your habits. It could very well be your genetics. And at this point, I'm looking, Dr. Zafar, we don't have it yet. AI has not figured out or at least we haven't figured out how to get AI to do this for us, is to kind of say, look into the screen and let's just read your genetics and then you'll know what's what. That's coming, right? That's very Jetsonian, right? Jetsons back in the day. Right. And I'm sure that's going to come, but we don't have that now. And so people, because you're born, you have genetics. You have a mother and you have a father. That means you have genetics, and you should be about the business of checking what your genetics are. And by that, I mean not necessarily going to get a genetic test, Dr. Zafar, but by going to see to what end. To what end has my genetics caused end organ disease, is what, Mary, is what Dr. Zafar and I say when we say, is there kidney disease? Is there diabetes? Is there brain disease, heart disease, GI disease? Is there a disease? Has my genetics and my behaviors, my composite of those things, led to some kind of organ damage and disease? If you don't test, you don't know, because not everything that can harm you hurts. I say that to my patients all the time. Not everything that can harm you hurts. That means there's a lot of stuff that goes on and there's no symptom until it's too late. The most pressing and urgent question we all should be asking is, have I had a heart evaluation? Period. End of story. If you have not had a heart evaluation and you are over the age of 40 with average risk, then that should be your most urgent thing. Dr. Zafar, you're absolutely right. The urgency is there, no matter how great you feel. We just gave the example of a marathoner. If you have increased risk, you should be doing that much earlier. And that conversation should be with a doctor whom you partnered with, whom you've hired. It's the only way to do it. It's the only way to get these tests at this point in technology, is to go and partner with a doctor. And that's the message.
And as important as this is, and as how many, the numbers, reflect how many die every year of this, is this part of the Medicare prevention checkup that happens every year? I mean, I've had one or two of them. I don't remember them focusing on heart issues at all with me.
Not at all. Not at all. Not only do we have a PR problem, we have a marketing problem, particularly cardiology, right? So I will tell you, Susan G. Komen in breast cancer has no problems with marketing. Right. Anytime you can get a burly defensive end to wear pink from top to bottom, you don't have a marketing problem. Okay, decidedly. We have a marketing problem. The fact that what I just said to many people is going to be news means that the purveyors of that information haven't gotten the information out. Remember, I went back to that story of why I went on television in the first place. We haven't told people that while your breast exams and mammograms are important, while your pelvic exams are important, while your PSA and prostate exam is important, the colonoscopy is important, the most pressing and urgent thing that everybody in the United States should be doing is looking at their hearts. But guess what? We haven't even told people what is the age at which you should start to get a true heart screen, stress test, echocardiogram, and a coronary calcium score. Well, if I asked you, when should we start screening for colon cancer? You both would say 45. The guidelines just changed. That's right. And some people have to start much earlier. Some people, we still remember 50, but at least you have some kind of memory about it.
Reference on it,
We,
yeah.
we don't have that memory around the number one killer in this country and the number one killer in the industrialized world. Why is that? What is going on? Right? So if we just can say to ourselves, it's not like one is, we don't want you to stop doing one for the other, right? Just because I want to save the whales doesn't mean that you should not save the koalas too, right? We can do all of it. I want to save your heart, but I also want to save your breast tissue. I want to save your prostate. I want to save your colon. We can do it all, and you just put it on your calendar that way. It's just that simple. Now, I know that there is an access issue, and I talked about this yesterday at a panel. Just because we can't get everybody to do the heart exam doesn't mean that we shouldn't be getting some people to do the heart exams, right? We could say the people who have employer-backed insurance, even our friends, they don't have that heart exam. And I want people to just say, okay, the guy's a little quirky, he's a maniac, and he's jumping out through the screen, but I think he may be right on this one. Let me just go get a heart screen. Stress test, echocardiogram, coronary calcium score. Start there.
Yeah. This is all good stuff. I mean, I've got my wheels are turning, and I mean, you see me being quiet. That means I'm thinking of somebody I want to introduce you to. Atif knows this. When I write things down and I'm quiet, that's what's going on. Atif, what is going through your mind as you think, because you have an entrepreneurial brain, and I know how you think.
I think one of the questions that comes up is one of cost, and as you said, accessibility. I mean, how easy it is to go get a stress test and an echocardiogram, and those they take time out of your day. You have to schedule them. You might wait in line. They may,
the doctor has to refer you for that, don't they? Or else your insurance won't pay.
Right.
Yeah.
But the bigger problem is that I think that when we don't have any symptoms, us physicians don't order those tests.
Yeah.
We sort of have a prejudice to not order the tests because we don't see the patient having an issue. And we think, we've been indoctrinated to think that if you don't have a problem, you don't order a test. Cardiology, that has been as Dr. Montgomery mentioned, it's very important to develop the guidelines for screening for heart disease, and we don't have that yet. We do things like cholesterol screening, we do things like diabetes screening, and those are the risk factors for heart disease, but we don't actually screen for heart disease. And that's a big issue. I think that
I'm on medicine for cholesterol. Have been for a few years. Yeah.
The other question that comes to mind is, are there simpler, and cheaper tests we can order that could replace the echocardiogram, the stress test, or the calcium score? Are there biomarkers that one could use as an initial screening test for heart disease, such as maybe, inflammatory markers or other types of things that could potentially indicate a problem? The more expensive, more time-consuming tests could be secondary to that, and that we screen with those biomarkers a lot earlier than we normally would, in the 30s possibly. In my own readings, I've kind of been led to believe, and this is probably what happens, is that plaque develops when you're in your baby years. I mean, fatty streaks start when you're in your early teens, or even before that. By the time you're 40, you probably have a 40% plaque burden. By the time you're 60, you have a 60% plaque burden. And there may not be significant plaque, but you still have plaque. So everybody gets it. The question is what is the most effective way to screen for that? Calcium scoring is definitely one method. Are there other things we could potentially do to discover the plaque burden that you might have that could herald heart disease? These people that have sudden cardiac death, are those that have soft plaque, that have non-calcified soft plaque? Because what happens is pieces break off, they go embolize distally, all of a sudden you have an occlusion of a main artery and you have a heart attack. So it's that kind of soft plaque that's more dangerous than someone who has a senescent hard calcified plaque, because that plaque likely is not going to rupture. It's the soft plaque which develops earlier in life, than the later plaque that could be the culprit in these sort of sudden heart attacks. And so quantifying the degree of soft plaque you have, either by a CT imaging or some other modality, could be an initial screening test for your risk for heart disease.
Yeah, fantastic. I think, I mean, obviously you're on the cutting edge of coronary atherosclerosis, the sort of in the weeds detail that we have to know as scientists, physicians, practitioners, purveyors, and then provide that information so that we can save lives. Here is what I think happens just in my lay sort of evaluation. The reason why those exams are more expensive than most people can afford is because of supply and demand economics.
Right.
We don't use it enough. When the plasma TV first came out, nobody could just go and buy a just wait a year and a half and the thing's 50% less. Well, because the demand went up. You see, technology is a little bit cheaper now. Same thing here. We are still in the Stone Age with regard to getting people out to do these tests. If we had the people in droves who could pay for the stress test, echocardiogram, and calcium score, all three are important because you get three different things.
Exactly.
Three different sets of things. Then the price would go down. So if everybody who had employer-backed insurance could go get their screen, the people who couldn't pay for it could be paid for. It's just an economics, and I don't know the economics jargon, but you get what I'm saying. It just makes sense. We're just not doing it enough. Now, when it comes to the cutting edge of learning more about coronary disease, remember I said we know what causes it, but we don't know all the details of it. I spent 4.5 years in a basic science research lab pipetting away at myofilament activation. You would think that we knew what troponin T, I, and C did together with tropomyosin and myosin. No, we're still learning that stuff. There's still more to learn. That was a very nuanced little thing there, Mary. That was a shout to Dr. Zafar. But the point is this, that we've got all of this information and we've got a lot of information, but we don't have all the information. Right. There will be a time, Dr. Zafar, when I can look into an otoscope-like machine, an MRI or a PET scan, or you can, take a blood sample and see if I'm about to have a heart attack. We're not there yet, to the point that you're saying. Like, a guy's coming in, he's 35 years old. Does he have advanced streaking? And you're absolutely right. There was a study of military vets in their teens and 20s at the time, and you could see fatty streaks in large vessels and coronaries. So we know that the process starts decades before we see it. And when we get to the point where we can find a marker that will tell us that that streak is there, and number two, we have the essential Drano, if we could liquid Drano it out, then heart disease then falls way, way down in terms of so we've got some advancing to do in science, and people are trying. But the key is, what can we do right now with the current level of access? Because access is a decades-long process, given all of the bureaucratic, it's just a big stodgy machine that we won't be able to turn around quickly. It's not nimble. What can we do right now? We can say to people, let's get your heart screened because it's the most important and urgent thing that you can do for your health right now in this country. And then the more of those people can do it, the cheaper it will be for us to do that. Now,
so we'll save money for everybody.
It'd be cheaper for everybody.
Including the insurance companies. Yeah.
Including the insurance company, because they would naturally say, okay, yeah, this makes a lot of sense. Yeah, let's screen everybody, because instead of paying 20 grand for a heart catheterization, what if I pay, $800 early on for a test, a combination of tests like stress test, echo, and catheterization. I don't think that it should cost more than $500 to get all three of them, but it doesn't cost that. With that being said, you talked about not being able to pay for it, and there's a whole large group of people that are fast becoming the predominant group of people in the country, and those are women. Women don't get screened enough. When we look at women, we say healthy. It's flattering, but it's not fair. It's not human physiology. You look at a woman, you say, oh, okay, you're fine. Right? We hear about the abysmal mortality. It's because we are assigning more than physiology gives us the objective evidence to do. We're not trying to not give top care to women. We just have an assumption that everything's okay. You are fine. Your blood test is fine. You don't have to go get this heart exam. And 200,000 women, at least, will die from heart disease this year that shouldn't otherwise die. So we're missing something, Dr. Zafar. The evidence is clear. let's start screening people and let's do it algorithmically. So the last part I'll say on this is that's where AI comes in. Tim Sarandos, who is the co-CEO over at Netflix, said, AI is not going to take your job. The person who best uses AI is going to take your job.
Take your job.
Right?
Yeah, there you go.
I said, that's great. Let me say that. This is the first time I'm saying it on airways. With that being said, think about this. AI can do so many things. One of the things that AI will allow us to do is to stop delivering disparate care. Whether it's to women, whether it's to rural, whether it's to Black folks, whether it's to other racial minorities, it doesn't matter. And AI, because it doesn't have a soul yet, at least at this point, because it doesn't have a soul, it doesn't make human inferences, interpretations, and it doesn't have a human perspective. So whenever I think about a Black person, it's not going to come into play as AI. I'm just going to say, this person has this disease. These are the 4 things you should do. This is a woman who's coming in with this set of risk factors. These are the things you should do. And it cuts out the disparate delivery of care. Now, guess what happens? You get the disparate delivery of care to go down, and you stop having these traumatic events where somebody's on a balloon pump and they're in the ICU and they're intubated for 6, 7, 12 days. That drives, Dr. Zafar, Mary, all 3 of us, our rates of insurance go up. Yeah. Makes it even less likely that somebody who doesn't have a job can get health care. You see? Yeah. So now we've got this thing. Let's act on what we can do now. And what we can do is give this information out, change the guidelines about when to get screened. Everybody go get screened. Let's start there.
2 observations. I think one, the messaging is fantastic. I think the messaging is right on. I think the messaging should go to both the patient and the provider, because the provider, in my experience, is not trained to screen for heart disease early, nor do they appreciate the need for screening early. So I think that's one change we need to make is, everything from medical school onwards they should be taught to screen for heart disease. Second, I think there's an entrepreneurial opportunity here to take the screening modalities and make them cheaper, perhaps in a mobile sort of screening unit like we do with mammograms. Could we do all 3 tests very quickly in 45 minutes? You go for a lunch break and you get your screening done and off you go. It could provide a method for screening mass amounts of people very quickly with minimal cost.
That's right.
I think if you were to kind of create
truck screenings, I love it. That's perfect.
And it works.
Allow you to do, exactly what you're talking about early on enough, and then it creates a sort of a crowd effect where if my coworker is getting screened, then I have to think about hey, am I at risk? Maybe I should go get screened. So it creates that sort of
the buddy thing too. They'll go together. Yeah,
domino effect, and it might entice other people within your community, within your work environment to get screened, and hopefully that momentum takes off, and then the direction of the culture regarding this changes, and that's how we make this happen. Think.
Women hardly ever go to the bathroom or Walmart without somebody else, another woman. So there you go. You got it. I was just going to ask that about from a telehealth standpoint, because, I have people in my network that do kiosks, healthcare kiosks, and building something like this into that, if it's possible, with doctors on the other end that can, telehealth in and monitor everything that's going on, because they are doing basic screenings. Very simplistic things. It would take a little bit more effort to do something like that from a kiosk standpoint. We're getting ready to talk to cities now here in the United States that are interested in these kiosks for those, I call them healthcare deserts, that are, far away from hospitals or clinics or anywhere else that people can't get to. So, this may be something that could fit into that if we could figure out how to do it. So you got my wheels turning. Before we ended up, I wanted Dr. Dave to talk about where you're headed. We know what you want to do. We got the message. Is there something big coming down the way?
I think, ultimately, my desire, and I've come to grips with it, and it's okay to have this as what my passion is, what my desire is. And I say it that way on purpose because we're not really taught as medical students to be okay with that. We're taught to, this is how you have to do it. And so it took a lot for me to branch out. I was supposed to be an academic physician. I have a PhD, and then, I was going to be an academic cardiologist. I loved the research. It was fantastic. But it didn't go to waste. I still use it every day. I still use the critical thinking every single day. But I'm okay with wanting to make a gigantic contribution when it comes to the message that we talked about at the beginning, which is my health is my responsibility. And Dr. Zafar added the subtext to that. It's not just behavior, it's my perspective, thought process about it, because many people just don't think it's going to happen to them. And that's real research. Research has been the placebo, nocebo effect, the health belief model. There's tons of research since the 40s and 50s around this idea that the mind has to shift first. It's got to be a mental diet shift. And I think we convince people to change their minds, like Dr. Zafar said, by having it be a critical mass effect. It's a herd kind of effect. You mean you all are going that way? I'm going to go that way, right? I'm going to do that too. And if we would just, the people who are going to listen to this and the people who will hear our voices talk about this will take that and then apply it in their own lives, then the numbers come down. And my next phase is, how do I continue in that same theme with the same passion? And so, yes, I'm looking for opportunities to increase scale of what I'm talking about. And I'm starting from the bottom. We restarted my podcast, and we're, every 2 weeks we're putting it out. We've got different guests. We're trying to appeal to different people to get them to listen to information in a different way than we normally do it in the conventional medical education delivery. And then, from my clinic, our thought is, how do we maintain exceptional care, leveraging technology and AI, but keep safety and quality intact? When people come to our clinic now, we started off as cardiology, now we have primary care, and that came out of pure necessity. It only takes so many years for patients to say, hey, do you have a primary care doc? Can you be my primary care doctor?
Yeah.
No, I cannot.
Yeah.
That would be bad for you.
Yeah.
But we can make that happen. And so
if they have that trust with you already, you might as well capture it while you've got them, because they want you to be.
And a model that works. So now it's expanding the model, going in retrograde, going back to where we were, when you could go to one place, see a primary, see the endocrinologist, see the pulmonologist, see the renal doctor right there. There's no inertia. No, you don't have to drive across town to go see the nephrologist. No, you don't. You're right there in the same center. And then you go downstairs, and it's, but in smaller capacity, because one of the things I know is true is that people don't want to feel overwhelmed by the environment. And so we pay a lot of attention to what our environment looks like. It does not look like a waiting room at a doctor's office when you come into prevent. It's on purpose. The colors, the way things are set up, it's all on purpose. And if we could just have that, I don't want to increase the scale too much, because again, you defeat the purpose. So you have people come in and feel warm and welcome. They're going to be more forthwith with information. And when they're forthwith with information, you can treat them more efficiently. You prevent mistakes, and you don't do unnecessary testing. But that's our goal in the next 10 years, to have enterprises that are throughout the country that really do exactly what we're doing in prevent, but just at a slightly increased scale.
So 2 observations. is I have had this concept for about 10 years. I've had the same idea. I call it omnifusion, and the proposal I have created with that, I'll send you the white paper on it, is the idea of a singular visit that not only contains a primary care component, but a specialty component as well. So you're actually putting priority on the patient's time versus the doctor's time.
Right.
So normally when you go to primary care, they might see you for 20, 25 minutes, make these referrals. You have to go to different clinics and different times, schedule them. Becomes a nightmare.
A nightmare.
For the patient who may not be able to travel, or maybe elderly, to get to those appointments, or may not have the money. So, so they end up missing these appointments. What if you could reverse the process and turn it on its head and say, okay, I'm going to schedule a visit for you, but during that visit, I'm going to have you see your primary care for the first 15 minutes. By a video conference, I'm going to chime in your cardiologist, your renal doctor, your diabetologist, They're going to all see you at the same time, one by one. They're going to agree on the care plan, and you walk out of there with a piece of paper that tells you exactly what you need to do, what tests you need to have. Everybody agrees. There's no duplication of testing. Medications are reconciled, and within an hour or hour 45-minute visit, you have your entire healthcare kind of adjudicated in one visit. That model, I think, would work, and that's the kind of model that would improve primary care effectiveness. Because right now it's not effective. I was in primary care for 15 years. I had an inner city clinic in Indianapolis, and saw all the indigent patients and how difficult it was for them to show up. I mean, they're more concerned about where they're going to get their next meal rather than showing up to the clinic to have their diabetes checked. So but if you could shift that perspective to say, okay, I can show up to clinic and I'm going to have everything done in one visit. I don't have to show up for 6 months. That will change.
And some of these people rely on caregivers, like what you're getting ready to face with your mom, Atif.
Exactly.
I go to a pain clinic for an issue with my neck, and I was there not long ago. And honestly, there was a woman that was supposed to be right behind me. An appointment was coming in right behind me who missed the appointment. They called her, and she didn't have a transportation. She didn't have a caregiver to come and transport her there.
This model is actually being deployed for executives and big companies who don't have a lot of time. So, for example, I have a very good friend who's a professor at Indiana University, executive level, and he flies to, I think it's Singapore once a year. And in one day, he has all his screenings done. And he walks out of there with a 100-page document telling him what his health is like. Then he came to me when I was his primary care doctor to say, here you go. Everything.
Yeah, here it is.
Busy executives that don't have time, but they need to be screened. That's the model they have. So there's no reason we couldn't apply that to the general population. It doesn't have to be an executive only privilege. I think if we were to reinvent healthcare to model it in that way, I think we'd be more effective. The second thing I'm going to offer is I'm creating a fund, Dr. Montgomery, and I'm going to fund you because I love what you're doing. It's right exactly what we need in this country. So we need to talk afterwards, and I can explain what's happening. And once it is launched, I'd be very delighted to bring you on as one of.
I think he needs to be an advisor on one of your healthcare.
Yeah, absolutely.
Things. Yeah, for sure. See, we're just doing business right here.
No, I mean it reminds me that there's never really anything new under the sun, but we don't get to cross-pollinate.
That's right.
And this cross-pollination, we owe this to Mary, who is just a natural connector. Like that is her superpower. I mean, I'm just learning, I'm just meeting her, but I'm just like, how many people has she done something like this to? Wait till the people see it. And there, so many ideas come out of this. And so thank you, Mary, for that.
I've already written down a few names.
Looking forward to the conversation around,
One's for you, the rest are for him.
Yeah.
This is good. This is fantastic, guys. So I just, I'm so blessed to have you both here. And I feel like just this conversation is going to bless other people out there who are watching. And if it saves one person a heart attack, or if it sends one person to get a screening, it's definitely worth it. And if it makes one doctor think about it a little bit closer, then we're doing a good job. So I want to say thank you to you guys. Hang with me a second. Everybody else, if you're watching this on one of the many places that you get your podcast, go to frontrunnersinnovate.com where you'll get this interview, but you'll also get some information on both these individuals that you're seeing here, and maybe ways to connect up. So we appreciate it, and thanks again, both of you. Till next time, happy front run.